I'm running a huge laboratory, and we have to combine, to be state-of-the-art, following the WHO and ICC guidelines, several very difficult and knowledgeable techniques like cytomorphology, histology, chromosome banding analysis accompanied by FISH, immunophenotyping, immune histochemistry, and an increasing number of molecular assays, not one gene only, but panel testing. And behind this molecular panel testing, there could be exomes or genomes or transcriptomes. And we are doing a lot of pilots to see where the gold standard techniques that are now available and have to be applied according to the guidelines, to the rules, to the classification systems, can be supported, or even can be, instead of being used, for those techniques we use right now. And therefore, not for today, but in the next 5 years, I see a lot of options using such huge molecular assays like genome sequencing and transcriptome sequencing to be implemented in our daily routine. And the NCCN guidelines, for example, for the diagnosis of AML, in addition or instead of the gold standard techniques, already write since March this year or use whole genome sequencing. So we are not so far away because it's already in the guidelines. So what we need is laboratories that are able to offer the complete spectrum of what is the gold standard today and what could genomes and transcriptomes add to this information. And going back and forwards with that, we will see quite quickly where the gains are, what we can overcome with these new methods in comparison to the so far gold standards, and where we should go. And I'm completely a believer that this will happen in the next 5 years, and we will find a very important central position for these whole-scale genome and transcriptome sequencing in the diagnosis for patients with leukemias and lymphomas as we deal here at this Congress. First of all, we need more experience, and we need gold standard controls to control what we see with these new standards. We have to go back and forward to see how strong they are, where we have more information, less information, and what can be done. Second, pricing, still the pricing. They are too expensive, but that will go down as many things go down that can be used in a high scale, automated fashion, and this is true for them as well. We need more infrastructure for these bioinformatics, because there's a lot of data to be used and to be bringing back to patients' reports, and therefore we need better, although there are a lot of them already, tools and software tools that make this data speak to us. And finally, we need regulation. When should it be used and when not, and reimbursement. And for the last point, reimbursement, the jury is still out, and we have to discuss this and convince all the regulatory bodies that these tools should be added, or maybe should be the only tools in the next 5 years for the diagnosis of leukemias and lymphomas and any kind of cancer, and I'm quite sure that will happen.